ADHD, there's a lot of things that can happen. Here's kind of an idea again. This is a better picture than the one for hypothyroidism of what it actually, the organ, what it actually affects. Because the patient is wasting away a lot of their nutrition, they could potentially have muscle problems too. So that's why it talks about muscle aches. What do you give a patient that has hyperthyroidism? You give them a couple of things of treatment here. If it's so bad, they'll go in and they'll remove the thyroid or half of it. And then so they have the other half and that half functions and it balances out. If they have to remove it all, they'll have to give them Synthroid, a thyroid supplement. So sometimes they have to go in with radioactive iodine and kill a portion of the thyroid. And so if they do that, if your patient has to ingest this iodine, what do you think would be the most important thing as a nurse to monitor for your patient if they ever had to receive radioactive iodine? It's a trick question. You as the nurse have a patient, they're in a room, they have received radioactive iodine. You know you can't go in there without protective equipment because you may be exposed to the iodine, the radiation iodine. You as the nurse, what would be the most important thing that you think you would need to assess on your patient?
Are they pregnant?
No. It's a trick question. The wheels are turning there. It's a trick question because you know what? When it gets said, you're going to be like,
okay, ask it again.
If your patient is in a room and they have received radioactive iodine because their thyroid is too hyperfunctioning and the radioactive iodine is supposed to kill a portion of that thyroid. All the things that I told you about thyroid, think about it. What is the most important thing besides putting on personal equipment, huh?
Heart rate.
What is heart rate associated to? But yeah, and so aren't those called vital signs? No. I'm asking you as a nurse and your patient's getting this, what do you think is the most important thing that you need to assess? And I told you it's a trick question. You were going to be like,
No,
right? No. I'm like, it's so simple. You guys are making it like super hard. That's the most important thing. It doesn't matter what else goes on in that room. It doesn't matter as long as you do the vital signs, right? Because if it's destroying thyroid, it's destroying parts of the hormone, it's destroying function. It could take the patient from tachycardia and hypertension to what? Bradycardia, hypotension. And so you don't want the patient to go there, do you? So keeping a sign of the vital signs will help assure that the patient doesn't get there. You know what? Airway and vital signs. Airway, vital signs. That, you can't go wrong. Airway and vital signs. And you have to understand, airway is always going to be first. If you look at the patient, they got to be breathing first, right? If they're not breathing, they don't have blood pressure. I'll tell you that right now. So, some of the medications that you might see is what we call propylthyracil. We refer to it as PTU. That's all I know it as. PTU. And then you have methazole, known as Tapazole or Northix. So these are meds that a patient with hyperthyroidism would receive. It's taking you from here out there. Stay with me. I'm gonna nail you down. I'm bringing some Gorilla Glue. All right, so this is the thing. When you give a patient PTU or Tapazole, there's a lot of things that could change. But I'll have you know this. One of the biggest problems that we have is that it's going to take 1 to 2 weeks before this medicine can start making a change. 4 to 6 weeks before it makes a significant change in the lab values. And it's a sad thing to think, but patients that have this problem are also going to be put on prednisone to take down the inflammation in their thyroid. And so it's going to make them very susceptible to infection. And so we don't want them with other people because they could get an infection, and that's going to complicate everything else. Now, the medicine we give them is going to suppress the function of the thyroid. It's going to suppress it. So what could be the biggest side effect that they may experience? Hypothyroidism and all the symptoms that go with that. That's one of the biggest side effects of the medicine, is causing hypothyroidism. And then, so when I say dehydration, you have to think physical weakness, low blood pressure, skin is dry, patient's lethargic. Okay, that's what you have to think of when I say dehydration. That's a big word for a lot of things. When I say hypothyroidism, that's a big word for a lot of things. You have to think about, what does that mean? Oh, bradycardia, constipation, hypotension, lethargicness, because it can suppress the thyroid too much. Are you with me? Are you sure?
Yeah.
So just think about this question while I go get my cord because my computer needs light.
You know what I'm saying? I'm done January. I ain't gonna I know what effect I had.
I don't have it.
Okay, great.
So I'm just curious, have you thought about this question? Like, how does the removal of the thyroid affect the calcium in the body? It can cause hypocalcemia. So the thyroid gland is responsible too for making sure that the calcitonin in the body gets converted to calcium. And so without the thyroid, you don't have that process happening. It's going to lower it. Absolutely. And if you have a parathyroidectomy, same thing will happen too. Now, you know, it amazes me sometimes, but I found patients in the public and they are physically distorted in physical shape. And then so as a nurse, you begin to kind of inquire about some things when you realize that there might be something regards to a disease process that they have. And you start asking questions and then they start answering them. And then you're like, oh, okay, now I get to ask it. What do you got? I got Cushing's. I knew it. I knew it. I knew something. I know it. But seriously, You will. You'll see patients, you'll see people walking into Walmart, for example, and all their upper torso will be like Humpty Dumpty and their legs will be like little sticks. And you'd be like, you'll start diagnosing them. Well, potentially Cushing's syndrome, patients look like that. They really do. Some diabetics do too. Yes, it's sad. Yes. All right. It is. So we're still in the same chapter. And if you didn't know, we were starting in chapter 9, I believe that is the, yep. Chapter 17, my bad. We're in chapter 17. This unit kind of goes to one unit and then it jumps backwards for a minute to chapter 9. We're in chapter 17. We're talking about adrenal glands. You understand that the adrenal glands are located on the top of your kidneys. They're responsible for secreting what we understand as cortisol, along with, as we learned in cardiology, epinephrine. But we're going to talk about the cortisol, which is also a mimic of prednisone, because prednisone is a steroid hormone. So cortisol is also that. So it helps to maintain normal glucose levels. Aldosterone is something else that is excreted, because we understand about the Ross system, right? When aldosterone gets secreted to try and create that hypertension. You're looking at me like you don't know.
We know.
Okay, all right, let's go. Okay, so anyway, we're going to talk a little bit about these two type of disorders. So Addison's disease is about the adrenal cortex, and we're talking about the adrenal gland, that it under-secretes the hormone, what they refer as that cortisol as glucocorticoid hormone. And if you look at Addison's disease, this woman is extremely skinny. Okay. So she doesn't secrete enough glucocorticoid from her adrenal cortex. She doesn't secrete enough. So when you look at the first 3 letters of this disease process, doesn't it say add? So when you see this, you should be like, oh, she needs glucocorticoid hormones added to her diet. That's how you should be seeing that. That helps to kind of keep it straight. Addison's, treatment needs to be added. She doesn't secrete, the adrenal glands don't secrete enough glucocorticoid hormone. So these are the symptoms that a patient with Addison's disease would potentially have. Untreated, it will progress to be worse and very difficult to try and reverse. Okay. What are the medicines that we use? We use what they refer to as a steroid production inhibitor. These are also identical to natural aldosterone. And don't get caught up in all these words, okay? I just need for you to understand that Addison needs a glucocorticoid hormone added, and Florinef is going to be that drug. And the one thing that I can tell you is that this drug helps sodium to be retained and potassium to be excreted. And what it will end up doing is helping to increase the blood pressure. So when I give Florinef, I'm going to expect that the patient has an increase in the blood pressure, because the medicine has created the environment for that to happen. It has attracted more fluid into the vascular system. That's all that you need to understand when it comes to Addison's. Does that make sense? Corticoids. Glucocorticoid hormone, steroid hormone, which is known as the Florinef. the Florinef, what's going to happen is it's going to make some hormone changes in the body, but it's going to help increase the blood pressure. Patients that don't have enough cortisol secreting through their body will end up having hypotension and a lot of other symptoms. But this is one way to treat their problem. True that they might have all these other side effects as well. Hypertension. Because if it's going to raise the blood pressure, what could it cause? Hypertension. It's going to raise the blood pressure. It could cause the blood pressure to be raised too much. And I talked about in the study session, you know, we learned about this in Unit 1, but for example, when we learn about drugs, you learn about the class, that's the C. Remember I said cakes? So C is the class. Oh, I can't spell. Class, action, knowledge. And then you've got the evaluation. And then you have side effects. Those are the cakes. Just like you see here. These are the cakes. Now we're going to go to Cushing's. So Cushing's is a disease process that is characterized by too much secretion of cortisol, also known as hypercortisolism. So if the patient has too much, they look like a cushion, don't they? You know, they just have too much. Addison's, we got to add to it, and Cushing's we need to take away. So Cushing's disease has all these type of potential presentation and symptoms: rounded face, upper body obesity, a fatty hump on the back between the shoulders. They have problems with hypertension. They have problems with hyperglycemia. So the treatment is really based on finding the cause of the production, and it may mean that they need radiation or partial adrenalectomy, or maybe the master gland is the problem. Striaea, which is stretch marks.
Oh.
You know, when stretch marks initially start, they're purple. Mm-hmm. I hope not. Well, if that's the case, we're going to give you a cortisol receptor blocker called cromolyn. It's going to help to reduce your cortisol production. And so you know what's going to happen? You might go into hypoglycemia. So I'm going to start talking to you about the signs and symptoms of hypoglycemia. You might start with a little bit of a salt craving. So I just want you to know, don't be buying all those bags of potato chips, and don't ask for extra salt when you go through the drive-through. And Danella, what is what? What H word? Here?
The Chinese word.
Right there, the H or S-U-T.
Oh, hirsutism? It means that you're going to grow hair. It's a good eye. It's not one of your vocabulary words, and it's going to come up. Uh-huh. Hirsutism. Hirsutism.
That's a word, okay? What is it mean?
As my husband would say, you're going to become a sheep man. He comes up with words all the time, man. I'm just like, where do you come up with this stuff at? Yeah, you're gonna become sheep man. So, just so you know, yeah, like spirulactone is frequently given with this patient too, to kind of counteract that hirsutism. Aldosterone, spirulactone is one of those drugs that are given to kind of counteract the hirsutism, the growth of the hair. Mm-hmm.
Oh, that's hair growth.
Yeah,
I missed that part. Okay.
she's becoming a she-man.
Right.
Now look at this. What is its evaluation? It's going to help reduce the signs and symptoms or the problems of the hypercortisolism by interfering with the binding of the cortisol in the receptors. It's going to act as an antagonist. Now, you can see here side effects. We want to make sure that the woman understands that this medicine could potentially be very harmful to pregnancy. So if a woman has this problem and she wants to become pregnant, she has to really work with her healthcare provider. All right. Do you need a 5-minute break?
No, no.
All right.
Should we put this particular receptor blocker on this drug? It's not on here.
It's not on there? The drug? Is that what you're telling me?
Like I'm on a diuretic.
Oh, so you could actually, you can add it, but I wouldn't stress about adding it. It's not there. I didn't realize that, but you could add it, but I wouldn't worry about adding it. Mhm. 6 to 12 weeks, what? Oh, all right. So let's just talk about diabetes. And this shifts us to chapter 18. Let's talk about diabetes. Is anybody here diabetic that wants to admit it? Nobody? Yeah. So sometimes we have that, okay, I can't minimize that. Okay, fine. Don't minimize. Let's see if I care. I have another way to get around it. I have on Moodle. We'll do it. No, we'll do it by Chrome. We'll do it this way. We'll do it this way. Where are you? Where's my library? Okay. I'm sorry. I just can't help this for a second.
This is a real B&H customer store.
Hang on. I can't help this. And then we'll get back onto track.
I see you found the snacks. Everyone thinks high makeup, but it's actually deep on. What's that?
Do you know what decon is made of? Warfarin, Coumadin. Decon is made out of Coumadin. Yep. But anyway, I couldn't resist that. It was a little off topic just to get a laugh out of you.
Oh.
I was just like, hey, uh-huh. All right. Where is, I'm looking for this one. Where is it? Where are you? Here she is.
In this film, we're going to explain how your body processes the food you eat in order to provide all your body cells with the energy they need. And also what happens when you have diabetes and this system doesn't work properly. When you eat food that contains carbohydrate, it's broken down in the stomach and digestive system into glucose, which is a type of sugar. We need glucose from food because that's what gives us energy. Carbohydrate containing foods are things like starchy foods, sugary foods, milk and some dairy products, and fruit. This glucose then moves into the bloodstream and the body detects that the blood glucose level is rising. In response to that, the pancreas, which is a little gland that sits just underneath the stomach, starts to release a hormone called insulin. And it's insulin that helps our body get the energy from the food we eat. The bloodstream then takes the glucose and the insulin to every cell in our body that needs it. To make this easier to understand, let's look at muscle cells. At the muscle cells, it's insulin that allows the glucose to get into the cells where it can be used for energy. It's a bit like insulin is a key unlocking the door to the cells so the glucose can get in. That way, the blood glucose level starts to drop. But the blood glucose level can be topped up at any point by the liver releasing extra glucose that it has stored. The blood glucose rises again, and again, the pancreas produces more insulin to move with that glucose through the bloodstream to the muscle cells, open the doors, and let the glucose in. The body functions best with the blood glucose at an optimum level. It doesn't like it if the blood glucose rises too high. Normally, there's a cycle within the body which balances out the glucose and the insulin level. And this is achieved by the food you eat, the pancreas, and the liver. However, in some people, the system doesn't work properly and they develop diabetes. There are two main types of diabetes, type 1 and type 2. In type 1 diabetes, the body isn't making any insulin at all. This is because of an autoimmune response, whereby the body has destroyed the insulin-producing cells in the pancreas. We don't entirely know why that happens in some people and not in others. Type 1 diabetes accounts for about 10% of all cases. It's most often found in the under 40s, and it's by far the most common type of diabetes found in childhood. In type 1 diabetes, the carbohydrate containing food is broken down into glucose as normal. That glucose then moves into the bloodstream. Normally, the body will produce insulin to let that glucose into the cells. But in type 1 diabetes, there is no insulin being produced. So the glucose can't get into the body cells at all. So the level of glucose in the blood rises and rises. The body tries to lower the level of glucose, tries to get rid of the glucose through the kidneys. That's why people who have undiagnosed type 1 diabetes tend to go to the toilet a lot to pass urine. As the kidneys filter the glucose out of the blood, they also take a lot of water with it. So the person with diabetes will get very thirsty. The urine contains a lot of glucose, and that creates an environment where it's quite easy for bacteria to thrive. So it's also quite common to get thrush or genital itching. In the same way, the blood contains a high level of glucose as well. So more bacteria than usual will tend to breed in flesh wounds, and they might be slow to heal. Glucose can also build up in the lens at the front of the eye, causing the liquid in the lens to become cloudy. That can mean that some people with undiagnosed type 1 diabetes can have blurred vision. Because the glucose can't get into the cells to be used for energy, somebody who's got undiagnosed type 1 diabetes is going to start feeling very tired, lethargic, and unable to sort of go about their normal daily routine. But the body still needs an energy source in order to work properly. So what it does is it starts to break down its fat stores, and that can lead to weight loss. So the main symptoms of type 1 diabetes are going to the toilet a lot, thirst, thrush or genital itching, slow healing of wounds, blurred vision, tiredness, and weight loss. These symptoms generally happen quite quickly, often over a few weeks, and can be reversed once the diabetes is treated with insulin. Type 2 diabetes accounts for about 90% of all cases in the population. It's most common in the over 40 age group in the white population, and in the over 25 age group in the South Asian population. Type 2 diabetes is a little more complex because there's slightly more processes at work. Either the body isn't producing quite enough insulin, or the insulin it is producing isn't working properly. That can be due to being overweight because a buildup of fat can stop insulin doing its job properly, but it can also happen in people of a healthy weight. So in type 2 diabetes, the carbohydrate containing food is broken down into glucose in the stomach and digestive system as normal. That glucose then moves into the bloodstream. The pancreas starts to produce insulin, which moves with the glucose through the bloodstream to all the body cells which need glucose for energy. However, the glucose can't always get into the cells because the locks to the cell doors have become furred up with fat deposits. That means that the insulin can't open the cell doors properly. So the level of glucose in the blood continues to rise. In response to this, the pancreas produces even more insulin. So the blood glucose levels continue to rise and the insulin levels continue to rise. This situation is further complicated by the cells, which are desperate for energy, sending out emergency signals to the liver to release stored glucose. The blood glucose level goes up and up, and the pancreas produces more and more insulin until it can't cope anymore, and eventually it can wear out. As with type 1 diabetes, the symptoms of type 2 diabetes are going to the toilet a lot, thirst, thrush or genital itching, slow healing of wounds, blurred vision, tiredness, and weight loss in some people. The symptoms for type 2 diabetes come along very slowly, and some people don't have any symptoms at all. So for that reason, people can live with type 2 diabetes for up to 10 years before they realise that they have it. Type 2 diabetes can be treated in a number of different ways. Initially, it may be sufficient to make changes to the food you're eating and to take extra physical activity or lose any weight that may be appropriate. But type 2 diabetes is a progressive condition and most people will need some form of medication to treat it.
So that is also located on Moodle underneath Unit 4, so you can watch it again. And I think actually, yeah, there's just one video. So it's right here. You can watch it again. And I don't know why it's hidden from students. My gosh. There you go. All right. I'm going to go back to the PowerPoint. So now we're gonna start talking about diabetes. This starts in chapter 18. First of all, when we talk about glucose, if you look on your standardized labs, you're gonna find that a normal glucose is from 70 to 100. Do you see it? Okay. So 70 to 110? Okay, 70 to 110. So this slide just needs to be altered to 110. So I would make that note, alter the slide to 110.
The bottom one is right.
Yeah, well, it's because, I don't know, I looked at something. Mm-hmm.
Just we had a test with that question on it and that was the answer 71.
You think because of fasting?
To where? Where did you have a test?
This is just- I guess was the answer. But that was the question. This was one of the choices. It was 71.
Look at this. Uh-huh.
Yeah. But I'm seeing the reason here. And that was the choice.
So the glucose should be from 70 to 110. This was last dated 7/22. It's because somebody had brought to my attention that one of these lab values was wrong. So I'm gonna print this for you because I think yours is dated.
3/20.
Uh-huh. So there's only been one change on there. It's not drastic change.
So it's just 70.
Yeah, so I'm gonna reprint it for you, so no worries.
No, it says 70.
I think in your book here, it's saying that a fasting blood glucose is less than 100, but we're going by your standardized lab sheet. Does that make sense? So you may see controversy in the book, but we're trying to keep everything very uniform, right? So if you saw a lab value in the pre-exam that marked you wrong, okay, so I need to go back and look at the labs and just make sure. Yeah.
And it didn't specify fasting, it just said. normal.
So, and it's true that when your patient is actually fasting, that's what you want to look at. You want to look at the time that it was drawn. Because if it was 4 o'clock in the morning, you know without a doubt your patient was fasting. Unless they have a G tube. If they have a G tube, they're feeding all the time, aren't they? And if the feeding wasn't stopped at least 6 to 8 hours before that lab was drawn, they're not fasting. So always keep that in mind. But we're going by your standardized lab values, no matter what you see in your book. Just to keep uniform, okay? So I think what happened was I looked at the book and I just put it on the slide and just kept going. All right, so glucose on the lab value sheet, fasting between 70 and 110. There's a hemoglobin A1C. This is a blood test that they do with diabetic patients.